It's my great pleasure to introduce Dr. Somnath Saha, who is professor, I'm going to read all of this, professor of medicine, public health, preventive medicine, medical informatics, and clinical epidemiology at the Oregon Health Science University. That's pretty cool, right? I know, it's very impressive. He's also a primary care physician at the Portland VA and a core investigator in the Portland VA's Health Services Research Center. Dr. Saha's work focuses on the influence of race and ethnicity in the doctor-patient relationship and its relationship to questions of disparities in healthcare. He's also a member of the Oregon Evidence-Based Practice Center, which conducts technology assessments and synthesis of evidence on effectiveness and cost-effectiveness of clinical services. I could stop there and we could learn a tremendous amount from Dr. Saha on all the other areas in which he is so expert and is doing such incredible and impressive work. But as a bioethics program, we've asked Dr. Saha to come and talk to us about something that is almost iconic in bioethics, and that is the ongoing story of what Oregon is doing with regard to priority setting and rationing. Right? It's impossible to take sort of any intro bioethics course that is concerned at all with questions of justice or healthcare policy and not get exposed to what was an extraordinary moment in American healthcare policy when the state of Oregon attempted to introduce formal methods for the allocation of scarce resources in the setting up of a health system. Many decades have passed since then, and I think many people are not aware of the fact that the work in Oregon has continued in ways that are very important for the rest of us to understand, especially in the context of American healthcare today. Dr. Saha currently serves as the chair of the Oregon Health Evidence Review Commission, which is the group that is charged with prioritizing health services, developing evidence-based guidelines, and guiding coverage policy for Oregon's public insurance programs, which is a long way of saying that Dr. Saha runs the group that does the work that all of us think isn't possible to do. So he's agreed to come and talk to us about that experience, rationing healthcare lessons from Oregon. Please join me in welcoming Dr. Saha.
Is this on? Should I be over here? Is this easier?
Okay. We should just tell you to go to about 1 o'clock.
Okay,
15
great.
minutes for questions. Sorry.
Okay, so I feel like I need to give a different intro to sort of lower the expectations. So I will say though that it's a little intimidating being here. I told some colleagues before I came here that I was going to go to the Johns Hopkins Bioethics Institute to talk about prioritization and rationing, and there was some snickering, like right, and then are you going to pop down to the State Department and give a talk on foreign policy? So I will just say that I'm, as Ruth said, I work on the commission that does the prioritization, and so I'm really just a cog in the wheel. So I do not claim to be a bioethicist. If you see things that seem like, huh, that guy doesn't know what he's talking about, it's probably because he doesn't. So, so really I'm just going to share sort of my experience over the last 8 years really working in Oregon on what we do for the Oregon Health Plan. So I'm really going to tell sort of the tale of the prioritized list, which is sort of the thing, the little baby that we coddle in the commission that I work on. I'll talk a little bit about the construction of the list, go through its heyday, which you know is past, talk about the decline and fall, and then what we've done in terms of reconstruction, and I'll share along the way some lessons that I've learned about how this works, and then talk a little bit at the end about the future of prioritized healthcare in Oregon, if it has one. Just a little bit of backdrop. So the backdrop for this story is in the mid-1980s. As you all probably know, healthcare costs were rising pretty rapidly. In Oregon, we had an uninsured rate of 18%. There were pretty rapidly rising emergency department visit rates, which was sort of got a lot of policy that our emergency rooms were getting crowded. And then there was a substantial amount of uncompensated care going on, and which resulted in a lot of cost shifting. Now, just the term cost shifting is sort of this thing that we talk about in health policy, and many of you probably know this story, but just to sort of go through what cost shifting is, this is sort of how it works. Patients are uninsured. Because they're uninsured, they don't really go and get primary care. They end up often getting their care in the emergency department. People who are uninsured tend to not have a lot of money, and so they often can't afford to pay their bills or pay all of their bills. The care goes uncompensated, so the hospital really just sort of eats the money. The hospital then doesn't want to eat that money, so they overcharge people who have insurance. The insurers then don't want to eat that cost, so they raise the premiums for the next year, which gives rise to the sort of ever-increasing inflation of premiums in health insurance. Employers then can't afford coverage anymore, so they drop coverage, and then more people are uninsured, and then the cycle continues. So this is sort of what we call the cost shift cycle. And people were looking to break this by trying to spend less money. Well, first people were just trying to sort of spend less money. The Oregon budget was sort of being eaten up by healthcare. And someone said, I think, let's look at our budget sheet and figure out where we can cut healthcare costs. Now, if you look at a budget sheet, you want to really sort of save money, you look for the big numbers, right? So you just look for a figure that's really big that you might just be able to sort of delete that row from your spreadsheet and then sort of go home and drink a beer. So when they looked at the spreadsheets, they saw that there was a line that said transplants. Now, transplants, as you know, in the 1980s were sort of soaring because it was sort of an emerging technology that was catching on fast, and there was a line item about transplants, and it looked big. And so in 1987, it was proposed to the legislature that we take transplants out of the healthcare budget, and done. It was done. So then what happened is then a kid got sick. A kid named Kobe Howard, who was 7 years old and had acute leukemia. His family couldn't afford a bone marrow transplant, and they requested from the state funds for the bone marrow transplant that cost $100,000, and that request was denied because we had cut transplants out of the budget. The family went around, raised money, they got to about $70,000, and before Kobe could actually get before they got enough money to transplant Kobe's bone marrow, he died. And this got a lot of national media attention. Those of you who were around in that day probably saw this. It made every network news's sort of cover story, and we were sort of billed as the state that lets children die. So our legislature called an emergency session after all of this news coverage and asked the question, do we want to be known as the state that lets children die? The answer to that among all the legislators was no. Nobody wanted to be the state that let children die. And they said, we have money, we can find money for transplants, but if we cover transplants, there's got to be something that gives elsewhere, right? We don't have an endless budget. So what will we sacrifice? And more importantly, what about we're talking about this kid that didn't get a transplant. What about the hundreds of thousands of Oregonians, including many children, who didn't even have access to basic health care? Forget about transplants, they couldn't get vaccines. So it turns out that at that time, the president of the Oregon Senate was a doctor. He was this guy, John Kitzhaber. He was an emergency medicine physician who also happened to have sort of come of age in the 60s. He was a hippie and was not afraid of radical change. So he basically stood up as the president, as the leader of the legislature, and said, we're going to have to ration health care. Now, it seems like a simple statement, but I don't think it was really, for a legislator to stand up and say those words, I mean, I think there were gasps in the room. I wasn't there, but I imagine there were gasps in the room. So, now, the reason there were gasps in the room is that when you talk about rationing, which has, if you read journals, people actually refer to it as the R word because it is a bad word in America, the word rationing. This is the image. This is why rationing gets a bad rap, because it conjures images of sort of Soviet kind of lines. You can see, I don't know if you can see the look on this boy's face, but it's fairly sad. I mean, he's standing there sort of receiving this gruel, and he doesn't look very happy. So that's what people think of when they hear the word rationing. But rationing is you know, it might conjure up bad images, but it's a simple concept, right? So this is the basic premise. In times of plenty, where you have enough for everyone gets a full portion, right? In times of want, when there's not enough to give everyone a full portion, you can do things two ways. You can give some people a full portion and leave other people completely without, which I would call inequitable distribution of resources. Or you could take your limited resources and distribute them such that everybody gets a smaller portion, which I would call equitable distribution. Forgive the kindergarten-y tone, but I mean, this is sort of, I think, sort of my way of thinking about this is it's really, you know, rationing is a bad word for reasons that befuddle me. So this equitable distribution has been called rationing, and if you take equitable distribution, which seems like a very fair concept, and you call it rationing, then people get really up in arms. So rationing really is just the equitable distribution of limited resources, right? And the basic premise behind the Oregon Health Plan, the way we decided to ration healthcare, was that basically we wanted to change the question from who is covered, which is typically what happens in health coverage, to what is covered. So we wanted to stop asking who and say what. Now, so the Oregon legislature basically passed a bill that said, yes, we will do that. We will make our healthcare coverage decisions based on what is covered rather than who is covered. We will try to maintain the population that's covered and just give everybody a little bit less so that we can make sure that everybody gets something. And then their job was then to look around and figure out how to do this. And it turns out that at that time, in the late 80s, no other state or even nation had really created a system to explicitly ration healthcare, which I think, at least talking to the people who were doing it back then, was surprising that no one had actually tried to do this. So there were no models to replicate, and they really had to start from scratch. So in starting from scratch, they basically started with principles. They wanted to lay a foundation. So they started with some basic principles, and these were the principles. There should be universal access to a basic level of care. And you've heard these principles now many times, probably because the Affordable Care Act embodies some of them. Society should fund care for the poor who can't afford it. That faced with budget constraints, we should limit services, not people. That the goal would be health, not health care, and that we would have to balance health care with other services, like education and other social services that are important to health. That there should be an explicit and transparent process to define the services to be covered. That process should include effective treatments for important conditions, should reflect public input and societal values, and that it should consider the benefit of each service to society as a whole, not necessarily to an individual. And finally, that there should be clear accountability for allocating resources so that everybody can see who did what. So to do this, the legislature basically commissioned something called the Health Services Commission, which was a group of people established in 1989. It was made up of the people you can see, 5 physicians, 4 consumer or purchaser representatives, 1 public health nurse, and 1 social service representative. Don't ask me how that composition got it. That was probably mostly politics. But that was basically the charter for the Health Services Commission. It should have those people. And our charge was to create and maintain a prioritized list of health services. So the idea, as many of you probably know, is that basically we would have a list of health services, and they would be prioritized from most important to least important, and then we would draw a line based on affordability. So the Health Services Commission then basically had to create this prioritized list based on the effectiveness of treatments and the importance of conditions. So it was not just what's most effective, but also what's most important, right? So important is not something that you can decide through randomized trials. It has to be decided through public input and values. So what they ended up with was basically creating condition treatment pairs. So there were 1,600 or so conditions and treatments, things like congestive heart failure medical treatment, congestive heart failure heart transplant, things like that. That's what a condition treatment pair looked like. They were defined, because this had to be an operational system, by ICD-9 and CPT codes. Those are the codes that we use to bill for diagnoses and treatments. So that's how the diagnosis treatment pairs got set up. And that becomes important later on because it turns out that these fancy ideas, when you operationalize them using things like billing codes, gets you into trouble. And then they took information on outcomes and costs, whatever was available from the literature, and then also just they relied a lot on the judgments of healthcare providers in our own community to basically sort of give input on the outcomes and costs of different treatments for different conditions. So then that was the outcomes and cost bit, but there also had to be sort of the importance factor. So they went to great lengths to get public input and sort of try to sort of elicit societal values about different healthcare services. They conducted 12 large public hearings to get people's input. They did 50 focus groups around the state, and they did a survey of 1,000 Oregonians to basically get everybody's input about how we should do this, how we should basically build priorities for healthcare. And these were sort of some of the things that came out of all of that, the surveys and focus groups and public hearings. These were our priorities, and they're sort of listed in kind of order of mention. And I think a couple of things are important to point out is that people really focused on prevention. People cared about prevention. They didn't want to get sick, which was in line with sort of the principles that they laid out, that we prioritize health, not health care. And then you'll see quality of life, cost effectiveness, ability to function. Those things were mentioned more frequently than, as you can see on the bottom right, length of life. So people were really much more focused on feeling good and healthy than on immortality. And then another thing that sort of was mentioned is mental health. So people in Oregon in the late 80s, early 90s were sort of all about mental health parity. So it turns out, so this is kind of an interesting story. So basically, with all of that sort of public input and sort of judging outcomes and costs, what ended up happening, and I wasn't there, so just don't look at me and wonder about why we did things this way. But what happened was that they basically said, well, we have to create a way to operationalize all this, and they created this formula. And this was the formula, and it's not meant for you to actually figure out. It's meant to just show you that there are a lot of sigmas and such that was basically this was the formula. This was really used, and we could break down sort of what every letter stands for. But the bottom line is that basically they created this formula because they needed to take these 1,600 services and put them into some kind of machine and spit them out in some kind of order. And they got a lot of smart people to do this, right? To really sort of create this formula and say, this is going to spit out the things in the right order. So then we learned a little bit about sort of the perils of complexity, because so one of the highest ranked services, and this is famous lore in Oregon. There's nobody that was involved in this process that doesn't know this. That one of the highest ranked services was treatment for malocclusion due to thumb sucking, right? And so this, I think it ranked number 10 or something like that. So people differ on sort of where this ranked in the list. But when thumb sucking was really near the top of the list, people figured out that the formula might have been wrong. Because all the numbers were right. They fed the numbers into the formula just correctly. But everybody sort of knew that this failed the sort of the common sense test. So this is sort of one of the first lessons that I took away, is that it's really, in doing this kind of thing, it's more important to be right than to be scientific. Not to say that being scientific is not part of it, but really, and this has informed the list all along, is that basically it's really, if you see something that looks that basically you can't figure out how the science got you there, but you know it looks wrong, it's probably wrong. So they ended up then with a simpler method. They basically took each condition treatment pair and sorted them into one of 17 different categories. And you can find on the web the long list of categories, but this is sort of what it looked like from top to bottom. Acute fatal illness where treatment resulted in full recovery was the #1 category. Preventive dental care fell in sort of around the middle, and then there was this bucket called inconsequential care that was number 17. That was basically everything we do that doesn't matter, which you might ask, like, why do we do that? Well, that's another lecture. So then the condition treatment pairs were then ranked within each category, and there was basically They were ranked according to sort of their scores, but then there was a lot of hand movement based on the fact that everybody knew that the formula didn't work that well. So then what happened is that so they created this list and they thought it looked good. It had about 700 plus condition treatment pairs, and they submitted it to the Department of Health and Human Services for approval. This was all being done through a federal waiver program, and DHHS had to approve everything. And they hit a stumbling block, which is basically the way that this has gone about was found to be in violation of the Americans with Disabilities Act. And the reason that that happened is that basically the public input was felt not to have adequately accounted for the views of people with disabilities. So views of people with disabilities were represented sort of in their proportion in the population, and people said, well, that basically trumps all their views because the people without disabilities are the majority. It also, they picked at the idea that full recovery, this idea that the first category was acute severe fatal illness with full recovery, that the concept of full recovery created a bias against the disabled, because the disabled would never get to full recovery. So basically they sent it back and said this is in violation of the ADA, and they said here's what you can consider. You can consider the ability of treatment to prevent death. That's fair. You can consider the cost of treatment, and you can consider clinical judgment. Those were the things you could do. So they went back to the drawing board and basically sort of reshuffled the list in a way that said, okay, this is how we're going to do it. And then they sent it back to the DHHS, and they said, okay, and then the list was approved in 1993. And then they sent the list to the actuaries to calculate the cumulative cost with each additional line on the list. So basically the actuaries go line by line and say, here's how much it will cost to cover the population up to line 1, 2, 3, all the way down to line 700, whatever it was. And then basically the idea was that, you know, once you sort of reach the budget that you set for that program, you draw the line there. Fairly simple concept. So February 1st, 1994, the list went live. The Oregon Health Plan was implemented. The Oregon Health Plan was a large package of healthcare reforms that ended up being a smaller package of healthcare reforms. It was an attempt to get universal healthcare coverage. It had two components. One was expanding Medicaid, which we now know as the Oregon Health Plan. The other part of the Oregon Health Plan that never came to fruition was an employer mandate to get everybody else covered. That never happened. So we refer to the Oregon Health Plan as the Medicaid expansion. And Medicaid became available to all Oregonians at or below 100% of federal poverty level. Always strikes me that, you know, what about those people, like, who wasn't covered under 100% of poverty level? Well, there are a lot of people. I think we were covering at about 64% at that point. So you were somewhere between 64 and 100, you were just not covered. The other thing that the Oregon Health Plan did was got a waiver to basically put almost everybody into managed care programs. So this is what everybody, now when the Oregon Health Plan went live, there was a lot of, you bioethicists had a field day. I mean, people went crazy about the Oregon Health Plan, and you fell on both sides of the camp. I mean, people really sort of had very strong opinions about sort of what this rationing thing was going to do, whether it was fair, whether it was going to be harmful or helpful, and I think some people sort of brought up these images of rationing. And in the newspapers, famously, our governor was called Dr. Death. There were specific newspapers that did this, not all of them. And then the OHP rolled out, and the reaction turns out to have been a bit different, and people sort of went crazy. I mean, people celebrated. It was fantastic. It turns out if you give uninsured people health insurance, they're really happy. It really does make people happy. And so this idea that universal coverage is a bad thing, I don't know who invented that concept, but it's wrong. So then we had our heyday. We expanded coverage to 125,000 extra people. It was a pretty large number. Our uninsurance rate dropped from 18 to 10%, really overnight. 90% of Oregon physicians participated. Our governor, being a physician, basically made sure that adequate physician compensation was part of the program. He basically said, if you don't compensate at the rates that at competitive rates, nobody's going to play. ED visits dropped by 10%, uncompensated care dropped by 30%, everything was looking good. Now, why did we have this heyday? Partly it was because we had a pretty robust economy. The 80s had been not such a great time. The 90s were a very good time, the mid to late 90s, as you recall. Managed care had been actually fairly successful in controlling rising medical costs. We got extra funds from the legislature and from cigarette taxes at the time, so there was money sort of streaming into the program. Provider reimbursement rates were high, and everybody was participating in the program. And I think importantly, nearly everything on the list was funded. The funding cutoff line was at 606 out of 745, and everything underneath 606 was stuff that most commercial plans didn't cover anyway. So this was another lesson that sort of people are okay with rationing if you don't actually have to do it. So when you create a rationing list and you cut the line where everything's affordable, then nobody really complains. So the Health Services Commission then was, after they created the list, their charge was to maintain and update the list, and they basically had to vet any new technologies that came along. We had to figure out sort of where to put it on the list. New evidence that came along, people would sort of bring to us things like antiviral treatment for hepatitis C that came along during that period, and we had to figure out sort of what to do with it. And then another role was to create guidelines. There are a lot of conditions with sort of varying severity, but only one ICD-9 code. This is sort of the tyranny of the ICD-9 code, is that things like psoriasis have one code, breast cancer, one code, right? So in creating the list, you couldn't really sort of separate, you know, stage 4 breast cancer from stage 1 cancer, stage 1 breast cancer, because it turns out that the ICD-9 people only gave us one code. For psoriasis, they gave us one code, and what happened along the line somewhere was that psoriasis, basically someone said, psoriasis, what's it doing up here? And someone knocked it down. And then some people came in and said, like, you know, psoriasis can be a bad disease. They presented a ton of evidence about how bad a disease it can be. And anyway, what happened then was we realized we can't sort of mistreat certain people or make bad decisions because the system, the coding system is wrong. So we created guidelines where basically we would say, okay, severe psoriasis gets this kind of care, mild psoriasis gets this kind of care, and we'll pay for it. And then there was expensive services that were sort of on the rise, like PET scans, and we had to create guidelines to sort of curtail their use. They were appropriate, but only in certain circumstances. So that's sort of what the Health Services Commission did from day to day. And then in sort of the mid to late 90s was what I call the beginning of the end. So medical costs continued to rise, and the state then said, okay, it's time for the list to go into operation. We're going to, you know, we want to keep this number of people on the rolls. We don't want to pay more money. So we're going to ask for permission to fund fewer services. We're going to raise the line according to what we can afford. And then 1997 hit, and we had to get permission from the feds to basically raise the line. And in 1997, the feds began denying our request for line movement. So in 1997, we requested an 8-line movement to go up the line, to go up the list for 8 lines, and they gave us permission to move 3 lines. They got stuck on line 587, which was venereal warts. So they said, you can't not cover venereal warts. Now, we made the plea, okay, well, they made the plea that you know, we've got about 500,000 people here who aren't covered for venereal warts or cancer, but they couldn't get around sort of the idea that we couldn't cover this service. It didn't seem like a benefits package to them. Then the decline. There was an economic downturn. We had very high unemployment rates in Oregon. This was sort of late 90s, early 2000s. We had a lot of diminished general revenues. We were unable to use the list in the way that we had anticipated because the feds were denying our line movements. Medical costs began rising again. Managed care, as you know, sort of fell by the wayside in terms of a cost control mechanism. Provider reimbursement rates, however, did not rise. We couldn't sort of keep up with we didn't have enough money to pay providers more money as they were getting from other places. And then we had a lot of providers that stopped participating in the program. So then our governor was now leaving office in 2002. Now that guy, I forgot to tell you that the guy that was Senate president, he then became governor in 1994. So he was elected governor. He was the governor from 1994 to 2002. So he sort of shepherded the Oregon Health Plan during its birth and adolescence. 2002, he was leaving office, and he wanted this not to completely die, and so he created what's called Oregon Health Plan 2. And what basically he got bold and said, we want to get coverage not just back up to 100% of federal poverty level, we want to get to 185%. So then what happened was he did a couple of things. He said, well, so the feds won't allow us to, you know, do much with this group that are federally mandated. And he said, we'll just keep that in one group and we'll call them OHP plus. And then this expansion population, the other people that we wanted to cover, up to 185% of federal poverty, we'll call OHP standard. And it was interesting to me that they chose this because, you know, plus and standard is how in commercial world they do insurance, right? If you have a crappy benefits package, they call it standard, and if you have a reasonable benefits package, they call it plus. And so then what happened was they reduced service categories in sort of a blanket fashion. They got rid of dental care, vision, transportation, and mental health. They got rid of mental health only for a short while because after they got rid of mental health coverage, someone jumped off a bridge in Portland and mental health coverage got reinstituted. So again, sort of stories, so bad stories end up changing policy. They put in co-payments, premiums, lockout periods. They put caps on new enrollees if they were short on funds. So in essence, basically what they did was revert to the usual way of doing business, the way the commercial insurers do it. Really, and so in my mind, they basically, in the process of creating OHP2, abandoned the principles that started the OHP. So society should fund care for the poor. We basically sort of abandoned that idea. Faced with budget constraints, we should limit services, not people. Well, we had to put caps on the number of enrollees. Fund services based on effectiveness, importance, public input, and societal values. Well, we basically funded services based on whether they were for your mouth or your eyes or for your brain or for your body. And so we basically sort of abandoned the principles, and after that really sort of was the fall. In 2004, OHP standard closed to new enrollment. By 2006, the expansion population that had reached its peak at about 125,000 came down to 25,000. We were back to an 18% uninsurance rate, and so 12 years after the initial sort of launch of the OHP, we were right back where we started. So this was another lesson for me, and this is not a rocket science lesson, that if you compromise principles, you compromise policy. So in creating OHP2, basically we abandoned all the principles that had started the OHP, and basically the OHP, in many people's view, essentially died. So now, by this time, I was on the Health Services Commission. I started there in 2004. I was on the commission, and there was one of the original commissioners, a guy named Rick Wopat, came to us and said, you know, why don't we do something? Why don't we try to, you know, get a phoenix out of these ashes? And he came with an idea, and he said, basically, we split the OHP plus and OHP standard groups because the feds mandate coverage for the plus group. They don't care what we do with the standard group. They don't care if we insure them at all, right? This is not a mandated group. This is just us doing this. Why don't we reinstitute the core principles of the OHP and cover fewer services and more people for that group? Why don't we actually make the OHP work for that group? If the feds won't let us do it for the plus group, we can do it for the standard group. And then he said, but first we should redo the list. So what were his reasons? Why redo the list? Well, so one was that in the back and forth with what was then HCFA, which is now CMS, some of the original principles and public values were lost because of the ADA thing, and all of that. Transparency was lost in the final method. There was just a lot of sort of behind closed doors hand movement of this versus that, and so really I think partly he said, you know, there's a lack of trust because people don't really know how this happened, and I will tell you that when you are a government-run, even though our commission is a completely volunteer group of citizens of Oregon, if you're viewed as a government healthcare entity and they can't figure out how you did things, people don't act kindly. And then the other thing was that over a decade had passed since the first list, and there were a lot of new evidence, new priorities. So Rick, I think, convinced us to basically redo the list. So in 2004, there had been a survey of Oregonians. Someone had done a survey basically kind of re-vetting our healthcare priorities, and these were some of the big standout priorities. Basic healthcare for all. People still believed in universal coverage. Infants and small children basically were a high priority. People thought that infants and small children should all be covered for their healthcare. Preventive and primary care should be guaranteed, and services should be cost effective. Right, so we were sort of in a pretty bad way financially, so people were very cost conscious. So then our job at the Health Services Commission was to reprioritize the list, and we did this in sort of the 2005-2006 time frame. And we approached the task with a focus on population health. We wanted to focus on populations rather than individual cases. We wanted to focus on health rather than illness, and as per public priorities, we wanted to focus on prevention and chronic illness management as sort of the things we wanted to really sort of prioritize in coverage. We wanted a simple and transparent process, no sigmas in the formula, and we had to pay attention to political feasibility given what had happened with the original OHP. So through a sort of a long process with lots of kind of discussions, we ended up consolidating our 17 categories into 9, and this is sort of the top, middle, and bottom of the 9. Maternity and newborn care, sort of in line with the priority on infants and children, was the top category. Comfort care was a category that sort of climbed up the list and went into the middle. And then this bucket of inconsequential care, which we're still doing, was in number 9. And then we had to create that explicit criteria to rate each condition treatment pair. The formula wasn't going to work. We didn't want to just do hand movement, so we had to come up with criteria. And these are the criteria we developed. So each line, each condition treatment pair, remember we didn't want to sort of completely reinvent the entire process. We were a volunteer group with limited time. So we basically took each condition treatment pair and we rated them for these various criteria. Their impact on healthy life years, and you can see the scores we were able to give them in parentheses. Their impact on suffering, population effects. Now population effects was basically if treating this illness will actually improve health, not just for this individual, but for the rest of the population. Things like tuberculosis or schizophrenia, where treating one individual's illness may have a larger impact on society. The vulnerability of those affected, so if in line with we should take care of our poor, if the people affected by a disease were more likely to be from disadvantaged groups, we gave points for that. The prevention of adverse consequences, so we knew we were going to prioritize prevention and chronic illness management, and we didn't want to get into the trap of saying, we'll cover the illness management for your congestive heart failure because we care about keeping you healthy if you have congestive heart failure. But we're not going to we're going to prioritize lower the myocardial infarction that got you into congestive heart failure, right? Because that's sort of this acute care thing, and we didn't want to fall into that trap. So if there was treatment for acute illness that basically prevented the development of chronic illness, we gave points for that. Then we gave points for effectiveness, as we had done in the original plan. And then we gave points for need for medical services. So this was sort of in response to thumb sucking, sort of it might be really effective, it might have, high impact, if in some people's eyes, but, how badly do you need medical care for this particular condition? And we gave a score for that, basically from 0 to 1. And then we had our formula, and we think this was a less intimidating formula than the original one. So we took our category weight, so whichever bucket it fell into, and we multiplied it by the sum of a bunch of different criteria. We multiplied that by effectiveness, because if a service had 0 effectiveness, we didn't care how much it affected the population. We didn't want to cover it, so it got a 0. And then we multiplied it by need for services. So if we thought that only 20% of people with this condition actually need to see a doctor for it, then it got multiplied by 0.2. And so this is an example of how things fell out. So this is just the example of appendicitis. Appendicitis fell on line 84. We gave it a 9 for impact on healthy life years because it can be a fatal condition. A 2 for suffering because it might hurt, but it's fairly short-lived. It didn't have, treating someone's appendicitis didn't have major effects on the rest of the population. People weren't particularly vulnerable. Appendicitis was sort of an equal opportunity disease. Prevention of adverse consequences, right? Getting someone's appendix out can prevent real badness, so it got a high score. The effectiveness of therapy for appendicitis is pretty well established. And the need for service we rated as a full 100%. And then it was in the category 6, which was our, I think, acute illness with effective treatments. And so it got a score of 3,200, which landed at line 84. So we then took that list, and then we actually ended up doing a little bit of hand movement here and there. There were things, hemorrhoids landed way higher than they should have, and we ended up doing stuff. But we actually, the hemorrhoids, what we were able to do with this formula was to say, okay, why is this, it seems out of place. We were able to go back to our formula and try to figure out where we got it wrong. And for hemorrhoids, we got need for service wrong, because most people with hemorrhoids don't actually need to see a doctor, and so we downgraded our need for service. And so, you know, you could say that that's sort of hand movement, but I think it was really, it at least allowed us a paper trail to tell people this is why it got to where it was. We took the new list and we went around the state. We did focus groups with various stakeholders, physicians, consumers and patients, hospitals and health plans. And then the governor formed a working group to decide what we should do next, because remember, we had done this to sort of go back to our OHP standard group and try to re-implement the principles of the OHP. So I was part of the groups that got together to decide what to do, and it was interesting. The discussions of reducing services made people very uncomfortable, especially the Oregon Medical Association, which is the group that represents physicians in the state. People just got really, really skittish about reducing services. For instance, when we said, let's say we wanted to cut services to below line 300, right? And people brought this up. That would eliminate coverage for fractures. There were various cancers that fell in the sort of 300 to 500 range, which was currently covered but wouldn't be if we moved it up. And people just sort of flat out in these groups said, how can we not cover those things? And then there were others of us in the group that said, we only cover those things now for 20,000 people. For another 600,000, we don't cover anything. We don't cover anything. So like, how can you get skittish about not covering this service for these 20,000 people? It doesn't make sense. And this is another lesson that I sort of learned that probably is not foreign to bioethicists, that when making coverage decisions, it's cognitively easier to take responsibility for the individual covered than for the population not covered. It was easy, even sitting in a room, not just, you know, a doctor, it was sitting in a room, the idea of not covering something just made people really, really sort of, it just punched them in the gut. Now, if we said, well, there are 600,000 people not covered, there was sort of a, those people aren't my problem issue. So you are deciding coverage for the people that are within your purview. People were able to sort of cognitively say, those people aren't mine, these people are. When I make a coverage decision, it's about the people that are mine. In the end, we actually turned out to sort of just abandon the whole idea. The juice was not worth the squeeze. The actuarial calculations revealed that moving the funding cutoff line to 300 would actually allow the coverage of an additional 9,000 out of that 660,000 people. And we said, well, that's silly. And it turned out that the problem was something called line zero. Now, line zero, I start to tremble when people say line zero, because what line zero is everything that happens before you get to a condition treatment pair. So basically, the way that the list is structured, again, remember, is based on ICD-9 codes and CPT codes. Condition and treatment. You have to have a condition to be on the list. Before you have a condition, if you only have a symptom, then you are in what's called line zero, and it is basically no holds barred, right? So all imaging services, lab services, ED visits, endoscopies, all kinds of diagnostic procedures are covered because you don't have a condition yet. And it turns out that line zero, when they did the calculations, were a third of the budget. So we were basically trying to move the line up against this huge brick that was sitting at the top of the list. So this was another lesson that I learned, that limiting portion sizes for the main course doesn't work if there's an all-you-can-eat appetizer bar, and people were eating at the appetizer bar. I mean, yeah. So what are we doing now? So basically, we're now grappling, obviously, with federal healthcare reform. We actually passed, believe it or not, about, I don't know, probably 9 months before the ACA, we passed healthcare reform in Oregon. We were all excited, and then federal healthcare reform came in and threw sort of a bollocks into everything. We were actually supposed to use the prioritized list as the platform for our benefits package in Oregon, and it was going to be our benefits package not only for the public programs, so not only for, we were going to use it for the Medicaid program, which it's currently used for, it was going to apply to other state programs like our public employees benefits boards, our educators benefits board programs, and then it was going to basically apply to anybody who wanted to play in the state insurance exchange. But then federal reform came along and reset the rules. So Right now, the prioritized list is still the basis of the benefits package for the OHP, and we've moved sort of into a different direction. We've moved into a frame of sort of creating what we call a value-based benefits package, where we try to incentivize high-value services, which means sort of no cost sharing for really inexpensive, effective care. So the stuff that hydrochlorothiazide for hypertension, which sort of is by not paying, by making people pay for it, you actually sort of lose money because people don't take the drug and they get sick. Flu shots, visits for chronic illness management, etc. We then have higher cost sharing for lower priority care, and then we try to implement controls on diagnostic care and ED visits, although that's a bit of a bear. So this is basically what our value-based benefits kind of framework looks like. For high-value services, so things like routine vaccinations, there's basically no cost sharing. We want to go out and get people and pull them in and say, use these services. And then we draw lines on the list, basically, and tier the list according to its priority. So people have really talked a lot about value-based benefits package, and we realized in Oregon we've actually got a structure that you could use to actually implement it. So we've got this list already. We can just draw lines and have different levels of cost sharing and different levels of service. So that's what we're doing. We're still in the process of figuring it out. We don't know if basically the way that the feds have scripted benefits packages is going to allow us to do much more. Although our then governor is now our new governor. We have a cap of 8 years, but it's only 8 consecutive years. So he ran again after the last governor. So our ER doc is now our governor again, and he's basically he doesn't want to see his baby die. So he's been doing a lot to get waivers from the federal government to do healthcare reform the way we want to do it. We did this thing called coordinated care organizations, which is our version of ACOs, and we've gotten a lot of money for it. So we're still hopeful that we'll be able to use prioritization as a way to structure benefits, but time will tell. So I think that's all I'm going to say. I just want to offer just a bit of thanks to a man named Darren Kaufman, who has basically been the director of the Health Services Commission since its inception, and is really kind of the fount of all knowledge and the reason that I actually am able to stand up and give you all this information. So thank you very much.
It's a terrific talk. Thank you. We have time for some questions. Please.
Yeah, I'm curious about how with the ACA, some of the challenges that are confronted in legislation development and everything else that's around it now concerns immigrant undocumented use, work area usage, reproductive health care services, tort reform, things like that that have gone up against it. How have the various iterations of OHP had to deal with those things?
So, I mean, the OHP basically is a mixed state and federal program. So we end up, I can't tell you how it's affected our work in terms of prioritization, but in terms of implementation and who gets covered and who doesn't get covered, we have to play by the rules. It's not to say that we always want to play by the rules or that we always believe the rules are correct, but yeah, we often actually do, every once in a while, in our role as on our commission, we will get basically, we work directly with our state office for health policy and research, and they will basically come and tell us about a new rule that affects what we're doing, and then we sort of have to change the way we do things. And so, yeah, sometimes we do things in a way that's not exactly how we would otherwise. Yeah.
Is the program dependent on a particular political party? Well, because I know that the governor is a Democrat. Would, if it had been a Republican or a Republican House and Senate, would it still gone through, or is it?
So would the Oregon Health Plan have gone through if it was? So I guess right. So I guess one insight is that when the first iteration of the Oregon Health Plan was sort of up in the legislature, remember it was two parts. It was the Medicaid expansion and then the employer mandate. So the employer mandate was entirely a political decision. It was the Republicans basically kind of weighing in and defeating the employer mandate. It was proposed with the Democratic legislature, then the Republicans got a majority, and then the employer mandate died. Would the OHP have ever been enacted if there was a Republican legislature in charge? Maybe not. Would this process die if Republicans were in charge? You know, it's funny because you would think maybe yes, because, you know, just anybody associated with rationing that's not trying to get rid of it on the Republican side of the aisle could be sort of, you know, called out by his party or his constituency or her constituency to say, what are you doing? That said, the OHP is so popular in Oregon that I'm not sure that, you know, that wouldn't trump everything. It's popular pretty much among everybody. Yeah.
Michelle and then Dave.
So you talked about restructuring the list according to new technologies. Is there a mechanism in place for revisiting the list in terms of changing community values?
So yeah, well, I guess the process is we don't have periodic, like sort of, you know, kind of sweeps of the population with surveys and focus groups. But I will say that the Health Service, well, we now call ourselves the Health Evidence Review Commission because we have an expanded scope. But the Health Evidence Review Commission is holds public meetings, and so all of our meetings are public, and we have subcommittee meetings that are all public, and so and there are people, interested parties, who basically keep tabs on what we do. So yes, people do come and say things like, you know, we think you're off the mark in this particular realm, and now it's difficult because we don't have the staffing or the resources to basically say, well, you know, is this just one person coming to us saying we're off the mark, or is there, you know, really, is this represent real public opinion? In some cases, we will try to figure that out. We will try to sort of go to a community that is represented by this person. The other thing we do is every other year we have to get the OHP has to get renewed every year. We have a sort of biennial review that the legislature has to basically stamp and say, yes, we can continue. And for the biennial review, we always sort of do something to basically say, are we doing things right? So we will go out to the provider community and ask about sort of something that's really sort of anything that's come up over that 2-year period where we've grappled a lot. So are we doing like for instance, and you know, Ruth knows this, in the last few years we've had to deal with sort of new cancer chemotherapies that don't cure but extend life, and sort of, you know, we've had to basically visit that issue, and so we sent out to all of our oncologists basically, you know, like, what do you think? What do we do with this? We ended up getting a whole subgroup to sort of revisit our policy on end-of-life coverage, palliative care coverage. So we try, but there's not sort of a kind of finger on the pulse of the state thing that goes on.
Like, along those lines, how difficult is it dealing with sort of the vocal minorities of if you have to kind of sort of help everyone, and then you have a small group that's maybe low on the list but really want something covered, and does that happen a lot?
Oh yeah. So we get advocacy groups in constantly, and sometimes we have to weigh it carefully. So for instance, I'll tell you that, you know, we had a group that came in to advocate for treatment of something called Hunter syndrome, and Hunter syndrome is a genetic condition that affects hardly anyone, but is devastating. There will never be randomized trials really of the therapy because there's too few people worldwide that have the condition. The treatment is enormously expensive. I mean, treating a kid with Hunter syndrome, and so we get, people will put that in front of our face and they say, like, you know, you're not covering this, you should cover it. And we try to do our best to basically say, you know, how much of this is just sort of one person's interest versus, you know, maybe we just got it wrong. It turns out that the people who were coming to us over and over again about Hunter syndrome happened to be the manufacturers of something called Elaprase, which is the drug to treat Hunter syndrome, and they had been basically going around to every state, and they were telling us how many different states we were sort of not in line with, and we ended up sticking to our guns because we actually were able to get data to show just the cost effectiveness, and it's a very hard thing to sit there and say, yeah, this kid with this devastating illness, we're not going to cover their treatment. But we have to basically say, okay, well, if we did, though, then we have to keep in mind, right? This is the thing about like covering the people in front of you, but not the people behind you, that there are 600,000 people behind us waiting to get in. And that if we cover this kid, then we throw another person back. So that kind of thing happens, yes, and we get a lot of people that come in. I mean, people are constantly coming in, and they come into, I think they come into Oregon, I think we get a lot of people, because, number one, because people care about what's covered and what's not covered. I think we end up getting a lot of people because we're a little bit of a bellwether, and people come in because if they see that Oregon's not going to cover something, they actually know that it's going to have repercussions elsewhere, because I think we have a little bit more of a kind of we have a little bit more of a process for making these decisions, and every once in a while we've learned from other states that they will basically look and see what we did to basically make their decisions, and so we end up getting a lot of out-of-staters coming in sort of saying, you should cover this, or you. So it's difficult, and we have to sort of, it's difficult to sort of balance kind of this, many of us are doctors, our sort of perspective as doctors saying, yes, we want to treat this person, versus our charge to basically cover the entire population. No, that's an answer.
Dave, did you have a question?
My question was pretty similar to Michelle's. I was wondering if you had observed, or since 1989, when you did at least one other round of public engagement, if the priorities had shifted in any major way, and as if that shift happens, should the marketplace essentially, I mean, you're kind of determining what the market, what the market is, should it shift with it, and just sort of. One of your last slides is showing I think it was sort of basically level of copay
You're right, yeah.
on the side. I just thought it was interesting that, I mean, I wondered if you've asked people what they would be willing to pay, or if they had $100 to spend, which of those services they would spend money on. I mean, because one might think that some of the things that people would be most willing to pay for would be up at the top, and you won't recoup any money for any of those services.
Right. So I guess yeah.
And tier 2 and tier 3 might still be pretty important to get, but maybe they're just off the radar enough that if people have to pay for them, they're not going to get them at all, which will save the state money, to be sure. But then, maybe people aren't getting services.
Yeah.
I mean, I'm sure you guys have thought of it round and round. But
no, I mean, no, it's a good point. I think, I mean, so when we really sort of have focused in sort of the tiering of the benefits package on sort of where they fall on the list according to importance and effectiveness and all the criteria. This idea of, some services we might not need to prioritize high because people are willing to pay for them no matter what, the sort of, the kind of economic aspect of it, we have explicitly not put into it. Now that you might say, well, that's not smart. From the state budget guy might think we're stupid for doing that, but we've tried to sort of maintain the sort of idea that we're creating a benefits package to promote health, that we're not basically acting as sort of people who are managing the state's money. People who manage the state's money can do whatever they want, but we've separated that because if you become like an insurer that is invested in sort of the money flow, then you basically create an Achilles heel that if you're a government entity will kill you. So we get accused of that even with our explicit process. We get accused of sort of making decisions based on what will make the state money and what will not make the state money. We had a famous case that I think some people probably know about where we denied coverage for a woman who had her third recurrence of metastatic lung cancer, and we just denied denied coverage for something that one of these new chemotherapeutic agents, and we were basically accused of sort of saving money on her back, and it got a little ugly. Yeah, I got a few death threats myself. So.
I'm really torn because I know the conversation is so important, and Joe had a question and other people as well, but we try to stop at 1:15, so I think we should just can I just make one observation that people may have missed? The members of this commission are all volunteers.
We're all volunteers.
So I think that not only should we be thanking Zom for the talk today, but for his incredible public service to health policy in the state of Oregon.